Hi, everyone. Jack Cush here in the room now. I'm with best friend, Dr. Leonard Calabrese from the Cleveland Clinic. We're talking about long COVID. A lot of this was actually covered at EULAR 2023. First off, Lenny, what do you think of EULAR 2023 as a meeting?
First of all, I was surprised at how crowded it was. I haven't seen the final numbers. You probably know more than me, but it was a real live meeting. And if you didn't know that COVID was the past 3 years, you wouldn't know much was going on different.
I know it was amazing. It looks like they're back in usual form. So today we're going to talk about long COVID, and thankfully Lenny has been really focused on this, and it's a big issue because New England Journal recently said that it affects 11% of people affected with the disease, and that means chronicity and disability for a lot of people, including our people. So, Lenny, why don't you give the audience just a brief overview of long COVID and how you got into this?
Well, first of all, this is not only fascinating and complex problem, but potentially a significant public health problem. But I will tell you that just as a setup, it's probably the most controversial thing in medicine that I've seen in many years. A lot of acrimony on both sides, but none of us are surprised at that about COVID. I've actually been interested in MECFS kind of under the radar with my rheumatology hat for 30 years. My immunology center created a biobank. I was on the board of directors of the National Association for Chronic Fatigue Syndrome. We wrote a lot of papers back in the 90s and early 2000s, and then as biologics segued, I kept seeing patients. I have many hundreds of patients that I follow. So it's a kind of a natural thing for me. The thing I find very interesting is that anybody that was interested in MECFS was largely marginalized. There was no source for any type of meaningful research support, and the poor patients are just brutalized as being complainers with very little empathy. And now, all of a sudden, there's a kind of a kumbaya moment to say that, wow, this is a post-viral sequelae and it's not new. So yeah, I find it interesting.
In many ways, this occurrence and its associations or likeness to fibromyalgia and MECFS, is probably sobering for those of us who don't want to discount those diseases and say that they have no origins that we can understand. You and Dan Claw recently wrote about this in an ARD article about COPCs. You want to tell the audience what COPC is?
Well, the notion that we have been studying fibromyalgia, which we now call nociceptive nociplastic pain syndrome in the pain world for decades, is an invaluable basis for research in long COVID. The cardinal symptoms of long COVID are fatigue, pain, sleep disturbance, and neurocognitive dysfunction. I don't have to tell any rheumatologist that we are, accustomed to this. I find it very telling. Eric Topol, my friend Eric Topol, wrote a recent review in Nature Reviews of Microbiology that has been downloaded 900,000 times since February. And as far as I can see, fibromyalgia was not mentioned a single time. Not even a word was mentioned in there. So there's like worlds apart. And the point that Dan and I made is that we know a lot about fibromyalgia. We know about the biology. We know about central sensitization and glial activation. We know that it's linked to immune-mediated diseases. We know that it's linked to intercurrent mood disorders. And there is a lot of evidence that long COVID is very closely aligned with this. but having said that, long COVID is a big umbrella, and there's a lot of different things under there. But rheumatology has a lot to offer in this. And the second thing I'll tell you is that rheumatology has a lot to offer in terms of our knowledge and capacity and our track record of classifying poorly understood diseases. This is a big deal. You know, we've been creating, robust classification criteria for decades. And here, 3 years later, we still don't have a good working definition for long COVID.
Yeah, I agree. I think rheumatologists are great at A, the recognition, and B, the empathy for the chronic pain condition and basically how to approach it. We could teach a lot of other people. So, I mean, I can go on and on about this long COVID and many questions, but let me ask you one before we get into EULAR content. And that is, long COVID has these very clear anatomic, pathologic, sequelae that you see in the lung, in the brain, in the heart. And can you draw, and no one has a problem understanding long COVID in terms of those symptoms, but they have a problem understanding the fatigue and sleep and all the fibromyalgia like stuff. Can you connect these two? Can you connect how it's viewed, I guess, how it affects the cardiologist, pulmonologist, and versus the rheumatologist?
You've hit this on the head. And we consider this as syndromic and non-syndromic long COVID. Everyone understands if you've been in the unit and ventilated for 2 weeks, you're going to have a prolonged recovery. We also see that people can develop, sequelae in terms of a number of things, and we'll come to autoimmunity in a moment. The pathologically based complications are much better understood than these non-syndromic presentations of pain, sleep, neurocognition, et cetera. So we're probably looking at two different things. The problem is that we now have thousands of papers looking at biomarkers, immune pathways, imaging, et cetera. And it's all over here. And yet we have not crisply aligned it with either these syndromic or non-syndromic presentations. Is there one or is there 100? Some people have said there are over 200 symptoms associated with long COVID. I don't even know what that means.
Yeah. So there was a lot of content at EULAR 2023 dedicated to COVID and how it relates to rheumatic conditions. What did you see that caught your eye regarding long COVID?
Well, the best paper on long COVID, and interestingly, it was just published this week in Lancet Rheumatology by Laura Bockel and colleagues, and this is a Scandinavian paper. This is a very carefully done study. This was based upon a prospective follow-up of patients with immune-mediated inflammatory diseases who then got COVID, who then could be followed by questionnaires to elucidate, signs and symptoms moving forward, and a control group, which is absolutely vital in these type of studies. And the long and the short of this really well done study is that, and they use the World Health Organization definition for long COVID, which for those that may not be familiar, you have to have symptoms that persist greater than 3 months after having incident COVID. The symptoms have to last for at least 2 months. The most common symptoms are the things that we've been talking about, fatigue and pain and neurocognition, but it could be any symptom that is medically unexplained. Now, it's quite a large umbrella, all right? Right. The Bockel and colleagues found that comparing our patients, the IMIDs patients, to the control patients, that there was numerically a slight increase in the number of patients who fit the long COVID definition, but after adjusting for covariance in terms of comorbidities and age and BMI, et cetera, that fell apart. So at one level, in a very nice study of a large number of rheumatic disease patients, numerically there was not an overexpression of long COVID in rheumatic patients versus controls. The real telling part of this study is when they looked at the common symptoms that are elucidated in the World Health Organization, and the ones we've mentioned, plus a number of others. What was found was that in patients that had rheumatic diseases who didn't develop COVID-19, they actually at baseline had a higher number of these symptoms than the patients that developed COVID and went on to be followed up. And the point is of this, and my editorial was that this shows the perils of studying a disease without classification criteria based upon unexplained symptoms. I've seen papers saying, if one symptom qualifies, it is, 3 months later, I'm sad, or I'm having difficulty driving a car. I don't know what that means. There's a lot of noise of symptoms in the general population, but I felt pretty good about this as it does nothing to diminish the reality of long COVID, but at least gives a first glimpse that our patients are not at any dramatically increased risk for this. And it's an important study.
It is, but it also tells us why we're in the mix, because as you say, all the things that our AIRD patients have are on the menu or of long COVID, but they're on the menu for lupus, dermatomyositis, and relapsing whatever,
Exactly.
So, yeah,
exactly.
Big issue. See, and so again, I think what the rheumatologist really needs to know is, are my patients at greater risk for this? I think that this is another piece, and there's been a mounting amount of evidence to say that there doesn't look like there's more long COVID. There's been some studies that say that there were, but I think that this has helped in our understanding. It doesn't negate the fact that we're going to have to deal with it.
For sure. Our patients are afflicted like everyone else, and they'll be asking us for advice. And that leads to the second issue, which I think is really important and will create a lot of consternation for us. And I think that we will have a lot to offer. And that is the debate of whether COVID is a meaningful risk factor for incident autoimmune disease. And the second presentation that I'll kind of engage you with was a really good debate on this with two big time people. On the one hand, the pro that COVID is a clear risk factor for autoimmune disease was Yehuda Schoenfeld, who talks about everything, it seems, in terms of autoimmunity. And then the naysayer was Robert Landauer, a very careful and brilliant epidemiologist. And I sat there for the entire thing, and I'll give you my magic minute summary of this. And I know this literature well. On the one hand, it is incontrovertible that patients after experiencing COVID-19, whether it be mild or severe, and there's probably a gradient, develop a plethora of autoantibodies. This has been shown using clinical autoantibody tests, and then antigenically agnostic tests looking at thousands of autoantigens. And whatever the reason is, there is an outpouring of these antibodies, particularly over this first year. And many rheumatologists have contributed to these data, such as P.J. Utz at Stanford and others. So there's a bunch of antibodies, but we're rheumatologists. We know that autoantibodies don't equal autoimmune disease. So the second part of this is that there are now 3 large epidemiologic studies that have been published. Two are still working their way through peer review, but now in COVID, we review these papers all the time before they make peer review. And then one published in Nature publication very recently that in concordance suggests that there is a palpable and statistically significant increase in incidence rate as assessed by hazard ratios for a long list of autoimmune diseases, including all of our diseases, ranging from rheumatoid, vasculitis, lupus, et cetera, et cetera, et cetera. And these are not trivial incidence rates or hazard ratios. And there will be a lot said about this in the next few months. This is probably, this requires an in-depth critique. The con of this was, here's the data. There's 3 major publications on this. What does it mean? And Robert Landue actually made a couple good points that we're pretty sensitive to. Number one, these data are all extracted from, TriNEC, TriX database, EMR, global things, looking at, every type of electronic registry that could be done. They tried to adjust for risk factors in terms of age, sex, very elegantly done. But he pointed out that none of them have access to clinical records. Number two, these studies are all subjected to, ascertainment bias. A patient has COVID, what's going to happen to them afterwards? If half of these people don't feel well, they go to a doctor. You're a woman, somebody orders an ANA and it's positive. What is the diagnostic code going to be from a non-rheumatologist, as we well know? So at the level of granular validation of these diagnoses, there's still some question marks. Yet the consistency across all of these diseases, I think, is of concern and really requires an ongoing curation of these data. And I think that it's going to take many months to next year or two to sort this out. But we could be looking potentially at a wave of new patients. And some of the diseases in there have red flags to me. That probably the greatest incidence of increase was in the area of vasculitis. So that's not one that that you're likely to make huge mistakes in diagnosing it. So I find this interesting, and it'll require ongoing work.
I've written about on our website that I felt that the data was pretty good, although it's all anecdotal and case by case, that COVID can cause the onset of what looks like systemic JIA and stills, and mechanistically, I think I can connect the dots. The spike protein activates NLRP3, and you're off to the races. And in that disease, the inflammasome gets activated, and those diseases are characterized by it not shutting off. And so there's something inherent in the host as to why that happens. I'm not surprised that that initial step could then lead to downstream, chronic aberrant immune responses that result in a variety of different conditions.
I think that this is a separate deal from the long COVID question. And,
right.
If you take these, billion people that have been infected with SARS-CoV-2, there are going to be a lot of, silent heterozygous gene mutations that are predisposing to a lot of different things. And it is, not clear what that interaction and how that will compound risk. But I think that we are going to be in business of studying this in significant detail for quite a long time.
So in summary, I think there are many pathways into chronic overlapping pain conditions like fibromyalgia, which is also long COVID, but COVID is the entry point, is it not? And then you were also saying that COVID is also potentially an instigator for the many common pathways that lead to autoimmune disease.
Yeah, think of this, the last point I'll make, the naysay, many people say that, throwing fibromyalgia into the mix of clinical expression for COVID-19, for long COVID is in some way pejorative, like, oh, that's just fibro. No, this is fibro. 50 to 70% of patients with ME/CFS meet criteria for fibromyalgia. If you women are more prone to long COVID than men, another risk factor for this. And then finally, if you look at epidemiologically the risk factors for fibromyalgia, every IMID that we have, rheumatoid arthritis, lupus, Sjogren's, etc., have an incidence rate of 4 to 5 times the general population. So having an immune-mediated disease is a risk factor for fibromyalgia. And here you have COVID-19 that cranks out autoantibodies like crazy. This shouldn't be like hard to get your head around, but it's the clash of silos right now. There's going to be a big keystone meeting on the science of long COVID in August, which I'm going to be going to, so I'm really looking forward to it. The last NIH meeting on this I went to, I was the only rheumatologist there, and it was interesting.
We're counting on you. You got to carry that flag up the hill, and plant it. But this is encouraging. I mean, I would like to know more about pain as it relates to my patients. That's going to make me a better doctor, a better rheumatologist. And I think that, if we can figure out mechanistically, the steps here, we can then have better interventions. And this is good progress.
Yeah. Well, thanks for letting me shout this out.
Excellent. Lenny, always good to talk to you. Have a great summer. Tune in the room now. Bye, everyone.